You know, imaging plays a critical role, I think, in the whole field of valvular heart disease, but especially in mitral valve disease. So I'm pleased to be joined by three experts in that. Dr. Vannan, who's from Atlanta, Dr. Ivan Salgo from Boston, and Dr. Alain Berrebi from Paris. So, gentlemen, thanks for joining me. You know, this is very interesting. Ivan, you know, you represent an interesting side because you're not only a cardiac anesthesiologist who's been trained in echo, congenital heart disease, but you also have been instrumental in the development of a lot of the technology. So appreciate you joining us. So let me ask you, where do we stand with imaging in structural heart disease today, especially for mitral valve? Where do you think we stand? Anybody?
I think if imaging has to play a continued role in influencing the art of mitral valve repair, I believe we have to bring the 10% science that it involves to the surgeon. I think that is the future of imaging as a general statement. I think if we continue to embrace only the art form, we will remain just an answer.
So you're really talking quantification and that. I mean, do you think we today, the cardiologists in Europe, and Ivan, you can jump into in the United States, or the imagers are really doing things in a quantitative, scientific way, or are we still, as Monty says, still in the art of it?
Yeah, so I think that the natural progression from 2D echo moving to 3D echo is the echocardiographer closer to the surgeon so that both understand the lesion in unity and understand the nature of the defect. I think with the ability to look at the structural defect now visually, both can speak the same language, and I think that's been showing itself in the operating room.
Actually, I'm a cardiologist, echocardiographer working in the OR, mainly in the surgical department, and I totally agree that it makes a major step for the surgeon, particularly because it provides the surgical view of the mitral. The dynamic statement, and not only the actual view, but also the ventricular view. Even the surgeon cannot see. So we make a very important step in this field to be more precise, to facilitate communication and to improve the results. Furthermore, maybe in all the etiology like ischemic march, multimodality imaging plays a very important role, particularly with the MRI.
So MRI.
Absolutely, for the volume, for the variability, and it's very important to consider now the modern approach of valve disease, generally speaking, in multimodality.
Let me ask you, you know, I'll come back to this because I mean, you touched upon an important topic, and that is that I'm not sure that a lot of the pre-operative, so the diagnostic workup echoes are done to the highest quality, the highest standards. Is that a challenge from us as imagers in this field? What do you think?
I think so. I think if we were to look at the future, I think I say there are three key things that we can do as imagers that will improve and make our role integral to mitral valve surgery, whether it be repair or replacement. And I think that is quantitation, automation, integration. Those are the three key things we have to do. And I think we are getting there, but we are not there yet in a collective fashion. Automation is important because most of this TE that Alain is referring to is done in the operative room setting. So the longer we take to generate any quantitative data, the less it is going to be integrated in the decision-making process. It may be of interest, but it may not be incorporated in the decision-making process. So automation and rapidity go hand in hand to a large extent. Clearly, accuracy is important, but I think automation and rapidity is important. And the integration of not only modalities, but information. Scar information from MRI together with mitral valve anatomy from 3D makes a very powerful physiological and anatomical substrate for surgery to use.
So Ivan, jump in. You wear two hats here, two miters.
So I think the key of what you're hearing here now today, Randy, is that able to look at the dynamic nature of the mitral valve and the disease process the way surgeons don't see it on bypass, and now looking at it in 3D. So we're looking at functional disease, functional MR, skewed mitral regurgitation. We've got to look at the mitral valve and the whole package. We've got to look at LV mechanics. We've got to look at how the mitral apparatus sits within the LV and LA function. And in looking at that, we can actually look at, as Manny is saying, we can look at automated methods to make quantification reproducible so that we don't have to worry what's the variation from one echocardiographer to the next. And then secondly, we can understand the disease process better so that in the future, as imaging continues to evolve and improve, we need to customize the type of repair better for that patient so they have better long-term outcomes.
So looking to the future, I mean, you know, we're now hearing some nice publications on strain on the valve and looking at the stresses on the valve and timing repair and things like that. Is that one of the advances we're going to have?
Yeah, absolutely. I think the ability to look at cardiac mechanics from a speckle tracking perspective and the ability to detect changes in preclinical disease before patients become severely symptomatic and identifying which patients need repair earlier is going to be key.
What about in the OR? So your surgeon to repair the valve, and you have not only to look at the anatomy and the physiology, but if you could do a strain map of the valve and say, you know, a lot of stress on A2, I mean, is that going to help?
It's very important to consider the communication between surgeons and echocardiographers, cardiologists, or anesthesiologists. The future has to be the standardization, to understand exactly the surgeon needs and how echo can really give the answer to this question. And there is a need for standardization, for example, valve analysis, talk about classification, segmental analysis, risk of SAM, tricuspid, to standardize the approach. It's very important. I think it has to be emphasized in the guidelines. And it's sort of new job for the echocardiography, so interventional echocardiography, not only in GOR but also interventional cardiology. There are many advances, particularly to have the imaging, the fluoro, maybe we can talk about this.
So I think a key area is looking at multimodality integrated imaging. So, for example, some folks know this after Navigator, but for mitral valve disease, unlike aortic valve, where the aortic valve is calcified, in mitral valve disease, we're talking about soft tissue, and ultrasound is king in soft tissue. So as we see newer types of catheter-based repairs coming down the road, the ability to navigate, place the device, and assess intraoperatively the adequacy of the repair is going to be key. And I think the future of imaging is going to bring, it's going to be the eyes for the hands of the catheter that are actually doing these procedures.
Your thoughts about flow?
That's, I think one of the things we have not done so well so far in imaging is to incorporate flow information post-intervention, whether it be a percutaneous or a mitral valve surgery. If you place a ring, for example, it changes the flow pattern during diastolic filling. That's a small example of science which the surgeons are interested but have never had it before. It may end up redesigning the type of ring we use, the type of ring we use, and the effect on the aortic leaflet function, for example. And there's another piece of science that it's an old concept, but we have an opportunity to address that in a scientific way that will enable surgeons even to do the current practice even better than they've done. And that's why I think bringing the 10% science to the 90% art form is a unique opportunity for us and have a real impact on the art form.
I'm going to finish up, but I have to sort of look at the economics of medicine. Maybe you have good economics in France. We've got shaky economics in the States. And I'm thinking, you know, we're at a time where there's decreasing reimbursement for so much, and yet we're talking about integration, new technologies. How do we approach that? Do we have key interventional images and play a role? What do we do?
I think if we are able to bring science to the art form and make an impact on clinical outcomes, I think what we do will have a value that even within the restricted amount of reimbursement that may be the future model, we may still have the major portion of that economics.
Yeah, I think in a capitated environment now, looking at outcomes and looking at technologies that bring the better outcomes to fruition and better efficiency is going to be the key, so that you're going to see the technologies evolve to improve the outcome.
It's really about the patient and that's getting the best outcome for the patient.
Absolutely. We have seen in the meeting that the intraoperative echo providing the immediate result has a clinical impact on the rate of reoperation. So for sure, inside echo, you can say that there is a residual amount. It's not good. We have just to correct it immediately and not to have a reoperation which is not so good for the patient and for the economy. I think finally there's a positive balance with the systematic use of intraoperative echo.
Well, I appreciate all of you joining me in this visit thing. We've got a great backdrop right here. Robert Dion talking over our shoulder, but thank you each. I appreciate what each of you have done in the field. It's great. Thank you.
Thank you. Thank you.